American Society of Diagnostic Intervention and Nephrology, Clinical Associate Professor at the University of Nevada, and Interventional Nephrologist at Lifeline Access Center. A presentation about the innovation in the vascular access in hemodialysis. تفضل يا دكتور.
Good morning, everybody. Thank you, Dr. Mahdi, for the nice introduction. Thank you to Professor Dr. Sharqawi and the organizer for inviting me second year in a row. As I mentioned last year, presenting in the presence of elite professors who taught me my first step in nephrology more than 15 years ago, put a lot of pressure on me. This year, I am accompanied by my mentor, Dr. Agrawal, the president-elect of American Society of Intervention Nephrology, and my mentor, so the pressure is doubled. So I'll be judged now by both. So today we're going to discuss innovation in vascular access. All stages of vascular access creation, maturation, and salvage. I think it's not moving. Can somebody help me? I'm sorry, there's technical difficulty. So I'm going to start till they fix, because time is running. So when we talk about vascular access innovations, it shouldn't be only about new technique and creation. I always say when you have an access center that managing vascular access, you have to leverage this access center in all aspects of access care. Vascular access, I always feel is like a human being with a life cycle. The life cycle starts with planning, and then creation, then maturation, then cannulation, and then dysfunction that happen if we have issues. There is more than 2 million end-stage renal disease patients that depend on vascular access as their lifeline. As I mentioned, life cycle of a vascular access have 5 pillars, and we talk about innovations. We're not talking only about new technique, it's all aspect of vascular access care. Starting with planning. Even planning for vascular access has to be creative. For so many years, we have talked about fistula first. Everybody have to start with a fistula. Data shows that's not really the right approach. And all of the data from Europe and United States lately shows that initially there was a good result, but later the result was going in the opposite direction. So patient who started with access, a functioning access dropped from 41% in Europe to almost 38%, and the United States also follows the same trend. We think that's because of the surgical fatigue. What surgical fatigue is? When you're focusing on creating fistula only, even in patients that have a high risk of failure of AV fistula, if you look at this patient or this patient, a vasculopath. That's what we call them, a vasculopath. There is no fistula will be matured ever in this patient. Their arteries calcified, their veins are exhausted. This patient shouldn't be a patient that you have to create a fistula. So the new innovation in planning is the right access and the right patient at the right time. You have to tailor your management for patient when you choose access. Depend on age, past medical history, and calculate risk and benefit ratio. If I have an 80 years old who is already negotiating departure from earth with God, like I tell my resident, there is no point of putting him through 5 surgeries to create a fistula. I give him 1 trial, and if he have a lot of comorbidities, catheter is okay. That's what I'm talking about, just tailor. Access creation, there is a lot happening in the last 5 years when it's come to catheter creation. For so many years, catheter creation was just a surgical approach that most of us are familiar with. Not the case anymore. There is an endovascular creation, and I know that Dr. Tamer talked about this last year. This is really now coming to the light, and there is a center, one of them is our centers that we started creating vascular access completely through endovascular technique. If you look here, that's actually how we create those fistula. You basically have 2 sheaths, one in the vein, one in the artery. There is no incisions, there is no stitches. And then using the radiofrequency energy, we can create a connection in 1 minute, less than 1 minute, actually a few seconds between the vein and the artery. And during the procedure, the post-angiogram, you already have a fistula that is created. In 4 weeks, you have a fully functioning fistula. You can add to that, there is no anesthesia. This can be done locally with local anesthesia or regional anesthesia. There is no post-operative follow-up. There is no incisions. There is no infection. It's a fistula. And you can add to that all of we know when we look at fistula creation, one of the big problems with intimal hyperplasia, that one of the reasons of formation of stenosis is actually the traumas that happen to veins when we manipulate them, when we do open fistula creation. When you manipulate those veins, like for example, radiocephalic AV fistula, when you look at the injury or the stenosis, usually as a juxtaanastomosis. Why? It's a clamp injury because of the way that surgery was created. So with this technique, actually, it's not only you have a fistula done in 30 minutes, also you don't have a lot of intervention needed to mature the fistula, and you have a high technical success and low intervention, future intervention to make the fistula mature. And here is the dream. The dream actually, have you ever felt that you really wanted a fistula that mature, never have intimal hyperplasia, never have anastomosis, never have stenosis, never have the dilatation because of the high flow? That's a dream fistula, right? We can do that now. So there is a new technique where fistula actually created in the lab. How they do it is really beyond the scope of this lecture, but it's a tissue engineered vascular graft that formed in a laboratory, and the initial data show a promising result. That's basically a graft that was created in the lab, and it was hooked between the axillary vein and the brachial vein, and you see the cannulation successful after 4 weeks, and you can see very nice patent graft with no signs of stenosis, and this graft is not going to dilate, is not going to have intimal hyperplasia because it's engineered. Maturation. When we create AV fistula, every 10 AV fistula, 4 of them only will make it to the dialysis center with no intervention. 6 of them will need a maturation. If you have a fistula that it did not mature in 4 weeks or 6 weeks, you can pray beside the fistula for the next 10 years, it's not going to mature. You have to intervene. An intervention is not surgical, it has to be endovascular because it's less cost and it's much better result. When we look at AV fistula, this is the dream AV fistula. You have an open arterial anastomosis, open juxtaanastomosis, an amazing body, and an amazing outflow vein, and an amazing central veins, and an amazing artery. That's the dream fistula, but we all know that's what we have. We don't have that when we create AV fistula. So what we do? وما نال المطالب بالتمني ولكن تؤخذ الدنيا غلابة وما استعصى على قوم منال إذا الإقدام كان لهم ركابة. عشان بس أقول لكم أنا لسه بتكلم عربي كويس. So for Dr. Agrawal, that's mean if you want something, go get it. So if you want something, go get it. One of the big issues with fistula failures that we gave up on them, right? I just met a group from Damanhur group. They were telling me if the fistula fail, they just move to the next vein, and the next vein, and the next vein. Well, how many veins we have? There is only 4 opportunity almost in a both arm. And I always say arms don't grow on trees. If arm grows on trees, we will be able to create how many fistula, but you have a very limited opportunity, and you don't want a 40 years old with a thigh graft. Very horrible way of living, and we all know that, right? So one of the beauty of endovascular technique is that you can really salvage fistula with a simple innovation. This is one of the cases that we have. That's one of my cases. This patient actually had regiocephalic AV fistula, and it was completely blocked. So we sent him to the surgeon. He created a jump graft. However, because there is a lot, that's what I was talking about, there was a lot of staples and a lot of fibrosis here. So even after the jump graft, you can see the fistula, here is the arterial anastomosis, here is the flow, nothing is going this way. And because nothing is going this way, you have a horrible retrograde flow in the radial artery. So how can we fix that? Just being persistent. You try to pass a wire, I tried, it didn't work. You go for a smaller wire, wires that you cannot even see. And once you make an access here, I was able to cross my wire. I put sheath on both ways. I used a very small balloon, 4x4, 5x4. This is all in 30 minutes. And then I started here, and that's how I end. I completely established flow in 30 minutes, and the retrograde flow in the radial artery completely disappeared. This fistula is salvaged, can be cannulated the same day. So that's the innovation. Don't give up in a fistula, and just use the right tools. You're like a plumber. If you know your things and you know your tools, you should be able to do it. That's another technique that can salvage every fistula, and it's very simple. Only $35 coil, which about 700 Egyptian pound. So this fistula actually is proximal regiocephalic AV fistula. Here is the fistula, but you can see nothing is going this way. It's very fading because there is a thief. So that's an accessory cephalic vein. This patient come back with difficulty cannulation because they can note the fistula very well because there is a thief on the side. That guy are stealing blood out of the fistula. How you approach that? Very simple. I introduce my catheter through the sheath. Here's the sheath, very tiny hole in the fistula. I introduce the sheath, I put my catheter, and then I deployed the coil. So that's an immediate embolization of the accessory vein. And here is the end result. Now the coil embolizing the thief or the accessory vein, and you have an amazing flow, right? This fistula can be cannulated also the same day. No catheter time, no loss of a chair time in a dialysis unit, better outcome. This case actually I think I showed last year, but it was not complete. If you remember this, I don't know if everybody was here from last year, but that's the guy who broke every bone in his body, didn't have much vein. He refused to have mini surgery. He got only one regiocephalic, was completely blocked here, and you see that there is no outflow. It's just, I would call a spaghetti outflow. There is no outflow. Cephalic vein is completely gone. This is just a bunch of collateral. Do you give up on that and just give him a graft in his thigh? No. What you do, or what we did, we selected one of the collateral vein and created outflow vein out of it. And that's the end result. And what I'm sharing with you this year, because he came back after completely mature, look at that. Amazing. Brachiocephalic AV fistula that did not have a cephalic vein as an outflow. This is all made up. It took me maybe 6 months to do it. I brought him every 2 months, but it was 30 minutes. I used a very small balloon, and here you go. And he's still dialyzing from this fistula till today. Now, fistula dysfunction. So fistula dysfunction is the last stage of fistula creation or maturation, and usually after you use fistula for several years, you will have intimal hyperplasia, and you start having thrombectomy. So this image from Dr. Tamer Wahid Said, he actually sent it to me last night. That's how they do the thrombectomy, open thrombectomy, which is absolutely fine. The only problem is that this is very invasive. Sometimes the incision that made above the fistula is in your way for cannulation, and shouldn't be the case. I usually don't send my patient for surgical thrombectomy unless they have a huge aneurysm and there is the risk of a high clot burden. Other than that, it's a very simple procedure. So that's one of my endovascular thrombectomy. So basically with 2 sheaths, no incision, no single stitch. I put 2 sheaths against each other, one going towards it, one in the direction of the vein, one of the direction of the artery, and then I pass. So I just confirm that my central vein is open. You see here, I got the catheter inside the artery. I inject, nothing is filling up here. The fistula is the graft is completely clotted, right? How do you open that? Through a small sheath. You go with the balloon, you do mechanical thrombectomy all over the fistula, the graft. You can use some machine like a drill, but they're very expensive, so I just use the balloon. And then you use Fogarty balloon. It's a thrombectomy balloon that you can go through the sheath, and then you go both ways. You clean the venous side, and then you go clean the arterial side, and suck all of the clots out through the sheath, and here you go. You have an open graft in 45 minutes. There is no single stitch, okay? And the last thing, even cannulation, you can be there is innovation in cannulation. How? Dialysis unit nurses really don't care about my images, how good they are. All they care about if they can cannulate the fistula or not. For them to have a difficulty cannulation and call the access center, and I say, oh, I'm sorry, my angiogram was normal. That's not satisfying to them. If the fistula is not ready for cannulation, you did not succeed. You maybe have an amazing images of before and post, pre and post, but unless you have cannulation done and be creative about it, you cannot call that angiogram and angioplasty is successful. So I love this case because this lady was 77 years old. She decided she's gonna have only one surgery done. And she said, I will never have another surgery. The fistula was created. As you see under ultrasound, it was very deep. So it was not meeting criteria for maturation, right? But the diameter was nice. So what we did, we used a Galaxy phone. You all use the iPhone and Galaxy phone, right? So we mark the fistula under ultrasound and make a map on a Galaxy phone, and then we show them where to cannulate. We told them not to go above. We actually give them a shorter body of the fistula because human being body don't read the textbook. I refuse to stick to a criteria. Guideline is there to guide you, not to really limit your innovation. This lady, even the body of the fistula, which by definition should be 6 centimeters, and this is the area that you cannulate. This lady has only 4 centimeters or maybe less. There was only 2 fingers between the 2 buttonhole, but she had a big diameter and she had a good flow. Her KTV was fine. She never had another surgery. They put that map in her chart, and that's what she was still dialyzing. So that's another innovation. Just think out of the box and tailor your care based on what you have. Thank you. This is just the man who inspired me all of my life for me to do this career, and it's my father who was dialysis patient and CKD patient and transplant patient. He was a patient of Dr. Sabri Bohar, and he was patient of Dr. Wissam Khadr, and he was patient of Dr. Ashraf Dunya. He was patient of every elite nephrologist we have, and because of this man, I am who I am today. Thank you.
Thanks, Professor Dalia, for your nice, interesting presentation. Only one question, only one, okay?
Intervention nephrologist, asking about 3 questions, please. First of all, in the vascular creation and wave fistula, we are doing 2 sheets, one in the arterial side, one in the deep system.
Yes, so they are actually in it. This is true. They are in the ulnar, vein
How
and
can you
the
calculate the
artery.
deep system after this creation?
Because they will, after you make the fistula, so I didn't go through in detail,
Yes.
but after you create the fistula, you embolize one of the vein in a way that will direct the entire flow to the superficial fistula, and then you will have a maturation fistula. So there is another segment to it. It's not that simple, but it's doable.
Okay, regarding the coil.
Yes.
If I put the coil, there is a risk of thrombosis of the whole fistula. The coil.
Why? So
I think
about,
the coil. I think the coil.
So the coil is an accessory vein,
Yes,
right?
you put it far. I see. Far away. You put it far from the fistula.
Yes.
But there's a risk of thrombosis of the whole axis.
Why is it, so how the fistula have a flow? From the engine, from the artery, right?
Yes, you depend that there is a jet flow from artery to the other one, to the main one. You put the coil in the accessory cephalic vein. You see?
Yes, that's true.
Yes. We have thrombosis in the coil, yes?
Yes, so the accessory cephalic vein will be thrombosed.
This thrombosis we have the risk to migrate to the axis?
No, it's not going to migrate because the inflow coming from the artery maintaining flow. Maybe Dr. Akwal can elaborate on that.
So what you are essentially doing is you have 2 parallel flows. Thank you. Excellent job, by the way. So for the accessory vein coiling, what you have is one main fistula, and then you have several other branches in it. So those branches are competing with the main fistula, and you want only that main fistula to be open. You don't want other vessels to be open. So if you put a coil in the other one, it will actually improve the flow through, because you are getting all the additional flow through the main vein. You will not get thrombosis. It's almost unheard of.
If you have a good blood flow, it's always an issue which is very important. You will not get thrombosis. Exactly the same in renal transplantation. Sometimes we meet patients with a migrating thrombus for the lower limb.